Welcome to our CME at SDMS CME accredited ultrasound webinar, Liver Masses When You Don't Expect Them. My name is Matt Wilson, representing the International Contrast Ultrasound Society, ICUS, in collaboration with Northwest Imaging Forums, the CME provider for this program. Northwest Imaging Forums is accredited as a CME provider by the ACCME. Northwest Imaging Forums designates this CME activity for 1.5 Category 1 credits towards the Physicians Recognition Award of the American Medical Association. Sonographer STMS CME is also provided for those wishing to receive up to 1.5 hours of Category A-B credit. The planner of this CME activity has nothing to disclose. Please find the Q&A button on your screen's lower menu bar to readily ask questions of the faculty as you are listening to their respective presentations. They will respond to questions in the discussionary period towards the end of our time allotted. It is now my pleasure to introduce our first speaker and moderator, Stephanie Wilson, MD, FRCPC, Co-President of ICUS, Clinical Professor of Radiology and Gastroenterology, University of Calgary, Calgary, Canada. Dr. Wilson.
Thank you very much. I'd like to welcome everyone to our webinar, and I'm here with my colleagues, Dirk Cleavert and Yuko Kono, who I will introduce further. And so this is a free educational webinar presented by the International Contrast Ultrasound Society in coordination with Northwest Imaging Forums, our CME provider. So on behalf of Steve Feinstein and myself, co-presidents of ICUS, we would like to welcome you to our webinar. And we want to thank those who have helped in planning our program. We express our appreciation to our friends at Northwest Imaging Forums, and we want to thank you for joining us for this exciting webinar. So let me tell you a little bit about ICUS. ICUS is a nonprofit global professional society that is solely focused on contrast-enhanced ultrasound. It includes physicians, sonographers, nurses, scientists, industry, and patients. And so it covers the scope of radiology, cardiology, hepatology, vascular, and gastrointestinal medicine in particular, although there are many more and more coming in the future. So the important thing that I'd like to share with you about ICUS is that we have no fees for anything. So for you to join ICUS, membership is free. In addition, if you come to any of our educational events, the CME is free, and you can watch these on your smartphone or on your desktop computer. We have free website access for a one-stop shop for everything to do with contrast-enhanced ultrasound. We have a free mobile app, ICUS Connect, and we have free CUS News Monitor reporting the latest CUS trends and developments worldwide. And so we'd like you to join, learn, and connect with us. And this can happen anytime during the year. And our website is listed there, www.icus-society.org. And as I say, you can join for free, and we welcome you as members of our society. Now, our commitment to CUS is an essential tool for modern ultrasound labs throughout the world for more than 2 decades. We provide safe, portable, radiation-free imaging that produces high-resolution, real-time images of the cardiovascular system, the major blood vessels and organs, and their tumor perfusion. It often reduces the necessity for downstream testing, it improves hospital workflows, and speeds access to diagnostic imaging and therapy. We also have a commitment to quality CUS education, and ICUS offers free CUS education for physicians, sonographers, nurses, and other ultrasound professionals. And we have webinars which can be watched live or on demand, and you can earn free CME for both. We are very well versed and present both off-label and approved uses of microbubble contrast agents. And we have a 2023 calendar and registration at our website for your availability. And so all live webinars, including our webinar today, will be recorded and available on demand at no cost on the ICUS website and ICUS Connect. So very briefly, I'll go through some of the other features. We have a sonographer training resource hub, which is scalable plug and play curriculum resources for sonography training and curricula. We have our new mobile app called ICUS Connect, and this is your gateway to contrast ultrasound at any time of the day. And our global news, our CUS News Monitor reports global trends and developments, and this is circulated to our membership every 2 weeks. And I'd like you to consider marking your calendar to join us for the 2023 International Bubble Conference held in Chicago every year. And this is a great pleasure at this meeting, and I invite you to consider your attendance, or you may watch this live on livemedia.com. I'd like to express our sincere appreciation and thank you to our sponsors. They are listed here from Platinum, Bracco, and Lantheus, the big pharmaceutical companies who manufacture the microbubble contrast agents, gold, silver, and bronze, and as well, we appreciate the unrestricted grant support from Bracco, Lantheus, and GE to help us support our ICUS Connect, the new ICUS app. And so today's agenda is listed here. So CUS, the unexpected, CUS in Fontan liver disease, and CUS in pregnancy, to be delivered by myself and my colleagues Yuko Kono and Dirk Cleavert. And I welcome you all to stay, please, for our questions and answers at the end, which is usually a most enjoyable time. So we thank you. We appreciate your interest in today's webinar. And to learn more and to connect with the global CUS community, consider joining ICUS, download the ICUS Connect, and visit our website and follow us on Twitter. So thank you for that opportunity to welcome you to our webinar. And I will now close this presentation and go to my own presentation on the unexpected liver mass. So I see that I didn't call my title exactly what I had suggested, but liver masses when you don't expect them is the total presentation, and I'm going to speak about the unexpected liver mass. And I'd like to thank Christina Merrill, who's my lead sonographer, who helps me with pretty well everything. These are my personal disclosures, which have no relevance to this presentation today. So let's start off by considering the CUS algorithm for liver.
Excuse me, Dr. Wilson. I believe we're not seeing your slides.
Oh, you're kidding me. So what do I do there?
Share, once you've launched your PowerPoint, then do the share at the bottom.
Sorry about that. Do you see it now?
Not yet.
No. Oh, just wait, just come back. I did share screen. I'm not quite sure why. Where is the green one? Pardon me? Yeah, but I don't have that one pulled then, do I? Better?
Yes.
Very, yeah.
Okay, good. We'll start right here. Is that all right? I don't have it in a slideshow yet. I apologize for this.
Excellent.
Perfect.
Okay, I apologize. So I'll just skip my disclosure page and I'll start at this page. So let's first consider the CUS algorithm for liver mass diagnosis. So while this is an excellent tool for the differentiation of benign and malignant liver lesions, we have to consider that everything is not always what it seems. And so certainly we're all familiar with using arterial phase and portal venous and late phase observations. So in the arterial phase, of course, our most important observation is arterial phase hyperenhancement, present in so many benign and malignant lesions. And then with bubble tracking techniques, we know we have a highly specific capability of recognizing patterns of enhancement that suggest benign lesions in particular. And in the portal venous and late phase, we're always looking for washout as a highly predictive monitor for the presence of malignancy. So these are safe and effective means of classifying liver lesions, and I'm going to present to you things that deviate from some of these rules. So everything is not always what it seems. So let's start off, first of all, looking at an indeterminate mass on an MRI scan, and the patient was ultimately referred to ultrasound for evaluation with CUS. So let's have a look at that case. So the first patient is a 67-year-old female with no known risk factors. And you can see that on her outside clinic ultrasound, they noted a small mass in the posterior aspect of the right lobe of her liver. And it looks rather like a small cluster of cysts. But the question today would be, is there anything around those cluster of cysts? In any case, the patient had 2 MR scans. This is the second, performed in 2022, so 3 years after that ultrasound was taken. So we can see on the MR scan that on the left-hand image, the T1 image, that the nodule is much bigger and that it's T1 bright. So therefore, on the arterial phase image in the center, we are looking at the subtraction technique, and we can see small flecks of increased signal within the mass, but very uncertain as to whether this is a vascular mass or not. However, when we looked at the delayed image, you can see that there's now considerable evidence of increased signal within the mass. And so this delayed enhancement, of course, no longer reflects the vascular pool on MR, and it suggests the presence of contrast agent that's in the interstitium of the tumor. So this was read as an indeterminate, uncertain mass, and repeat MR was recommended. However, in my institution, of course, we come to ultrasound. So almost immediately after this MR, this ultrasound was done. And you can see the mass no longer looks like it looked in 2019. It looks like a solid, very round mass. And when we go to CUS, you can see that when we inject the contrast agent and track the wash-in phase, that this is definitely a solid hyper-enhancing nodule, a globular enhancement pattern. So a solid mass. And when we look at with our later images, you can see that it's already showing washout or a decrease in its intensity below the liver signal by 1 minute. And at 3 minutes, this is very marked black washout. And so we, of course, feel this is a malignant enhancement pattern concerning for non-hepatocellular malignancy and recommend biopsy. And so what do we have here? Oh, I have my things hidden by your heads, Dirk, and you go if you could turn your video off perhaps. But this is a metastatic mucinous ovarian cancer. And so this was an unexpected observation from the MR report, but this is what we found. So what is our take-home point from this case? Well, it shows, first of all, that one of the biggest roles for CUS is filled in this case, and that is for the resolution of indeterminate masses on MR and CT scan. In addition, it shows an example of portal venous phase imaging discordance, whereby the ultrasound showed rapid marked washout on CUS, and the MR instead shows progressive accumulation of contrast agent on the MR scan within the the mass. And this, of course, reflects the different properties of contrast agents. On contrast ultrasound, we use purely intravascular microbubble contrast agents. Therefore, in these non-hepatocellular malignancies, when the bubbles are gone from the blood pool, the lesion quickly becomes washed out or black. Whereas on CT and MR scan, the recognized interstitial phase reflects increasing intensity of the signal within the tumor from interstitial contrast agent. So let's leave that and now look at 3 further cases that show APHE and rapid marked washout, suggesting non-hepatocellular malignancy. So let's have a look at these. First, a 45-year-old male with no known risk factors, and we can see a fatty liver and very black masses in the liver without increased through transmission, solid masses. So these are concerning in and of themselves. And when we look at them with contrast, we can see when we inject the microbubbles that there's obvious enhancement of the mass in the arterial phase. And by 1 minute, we can see that all of that enhancement is completely gone and that the lesions are again black. So this is very rapid, very marked washout, a concerning picture, recommend biopsy. So when we do this, what do we get? Not a malignant tumor, but an inflammatory pseudotumor. So not what we expect, but certainly what we encounter regularly, but infrequently on CUS. So let's go to another patient, a 38-year-old male with right-sided abdominal pain, and he had a mass shown on a CT scan performed as a KUB. An MR scan performed suggested it was indeterminate query metastasis. So when the patient comes to see us, this is the second injection performed on top of a washout zone. And you can see that that large mass has got arterial phase hyperenhancement. The peak enhancement image at 15 seconds shows the peak enhancement. But by 1 minute, we show partial washout. And by 3 minutes, this is marked washout. Again, concerning for a malignant pattern. And this is biopsy proven tuberculosis. Now, the last patient in this sequence is a 59-year-old male who has HBV carrier status. He comes to the emergency with right upper quadrant pain. This resulted in a CT scan, which shows a vague area in the liver with some low attenuation areas within, possibly an abscess, possibly some other kind of cystic mass. And the patient came from the CT scan to ultrasound, where we see a very heterogeneous, expansive mass, which is altering the liver capsule and involving the soft tissues of the abdominal wall. So when we go to our contrast-enhanced ultrasound, we can see hyperenhancement with small avascular areas within and enhancement of the overlying abdominal wall as well. Now, on the 22nd scan, we see that the major portion of this mass is hyperenhanced, and by 1 minute shows weak washout, but by 3 minutes, this is very marked. And at 3 minutes, we can see also that the abdominal wall and the mass are all markedly washed out. Again, a concerning pattern for non-hepatocellular malignancy, but on biopsy, this is IgG4 inflammatory pseudotumor. So the take-home points from these cases is that marked washout at less than 1 minute on CUS suggests non-hepatocellular malignancy in a normal patient, and it suggests the LIRADS category LRM in at-risk patients. Regardless, this category very successfully recruits patients with metastases and cholangiocarcinoma. However, it also includes other pathologies, some of them benign, especially inflammatory disease, as shown in the 3 cases I've shared with you here. So now let's look at 2 cases with similar observations. So let's have a look. So this is a female patient, 37 years old, no known liver disease, and a long history of birth control pill use. She's asymptomatic at the point of this scan. So when we look at this picture, this is a sagittal view of her liver. We can see a mass lesion that is in her liver, solid, no specific features, and we can see a subhepatic or exophytic mass that looks rather like complicated fluid. So again, we go to our contrast enhanced ultrasound, and when we inject the contrast, we can see avid hyper enhancement of the solid portion of the mass, and that the cystic portion of the mass is completely avascular. So we show APHE and we show no washout. So what do we think of this case? Well, let's look at the second one first. It's very similar. A 40-year-old male, recent landed immigrant with non-cirrhotic HBV. And we can see that white arrow points to an intrahepatic solid liver mass. And the yellow arrow points to an intimately adjacent, probably subhepatic complex fluid mass. So when we look at this with contrast enhanced ultrasound, we show in the arterial phase that the intrahepatic mass marked by the white arrow is clearly showing a globular hyperenhancement pattern, and that the mass marked by the yellow arrow is completely avascular. When we look at 1 minute and at 2 minutes, we can see that there's a weak washout pattern. And so we have a hyperenhancing mass with weak washout. So what do we know from these cases? Well, these patients have not a clear documented risk for patient A, and neither patient has a really contributory history. And we identify a perihepatic cystic mass. So in these cases, we always want to consider spontaneous hemorrhage. And so patient A, the young asymptomatic woman, has a ruptured hepatic adenoma, which is proven at surgery, and patient B has a ruptured hepatocellular carcinoma. So we'll end with 2 cases, A and B, with specific enhancement patterns in the arterial phase, suggesting a benign diagnosis on CUS. So let's have a look. So the first patient is a 74-year-old female with an incidental liver lesion found on CT scan. You can see it marked by the white arrow, so a hypoechoic nodule. And when we look at the wash-in bubble tracking technique, we can see that the mass is hypervascular. It fills from the center and goes very rapidly to the periphery, and it has somewhat of a stellate vascular pattern and centrifugal flow. So I hope that you're all thinking, is this an FNH? Now, let me just show you the other mass. This is a 38-year-old male with right-sided abdominal pain. He had a liver mass detected on a CT scan performed as a KUB. And so he has this big, unusual looking mass in his liver. And when we look at the fill-in of this mass, you can see an on-top injection fills from the periphery towards the center of the mass. So we know that can happen in some different masses, but this one, nice homogeneous mass, a patient with no risk. Is this an adenoma? So I hope that's what you're thinking. So let's look what we must do to resolve the questions. So on the first patient with the beautiful stellate centrifugal filling suggesting FNH, we have to look at the portal venous phase. So at 2 minutes, we have weak washout starting, and it becomes much more marked late. And so whenever we see this kind of washout, especially when it goes very marked like this, we can't rely on the arterial phase pictures. And so, of course, we recommend biopsy, and that's a biopsy-proven HCC. I have only a handful of those after doing this for decades. And so this patient, also with a centripetal filling pattern, homogeneous hyperenhancement. It's a male patient. There's weak washout at 1 minute, and again, very marked washout at 3 minutes. So whenever we have that marked washout, even with a benign enhancement pattern, we always biopsy, and this is a cholangiocarcinoma. So what are our take-home points from these 2 cases? Everything is, again, not always as it seems. So dynamic real-time ultrasound suggesting benign morphology is a guideline, and exceptions infrequently, even rarely occur, but as here, they can be cancers. So washout in benign tumors, when it occurs, is usually weak. And black washout, as I've shown you on these 2 cases, always warrants biopsy to exclude a malignancy. And washout discriminates hepatocellular and non-hepatocellular malignancy, as shown here. HCC with late and weak washout is an excellent indication of hepatocellular carcinoma in a normal and in an at-risk liver, and non-hepatocellular malignancy shows rapid and marked washout. So my conclusions that I have countless examples beyond these, but the ones we've looked at is inflammatory pseudotumors and masses frequently mimic non-hepatocellular malignancies, or LRM, in at-risk livers. Dynamic real-time enhancement patterns suggestive of benign tumors require confirmation of malignancy by observation of the portal venous phase for sustained enhancement. And if we have marked washout, we must biopsy these lesions. And spontaneous hemorrhage and rupture of liver tumors is attributed to tumors of hepatocellular origin almost exclusively, including hepatic adenoma and hepatocellular carcinoma. And most important of all, on several cases I've shown you, CUS is fabulous for the resolution of indeterminate MRI scans. Thank you for your attention. Now, with that, I would like to start screen sharing with Yuko Kono, who will speak to us about Fontan liver disease. Dr. Kono. Oh, Dr. Kono, I didn't make any comments about you. Dr. Kono is one of our dear friends, and she was the former head of the LIRADS working group. She is a hepatologist in the University of California, San Diego, and is really an expert in liver disease. Dr. Kono.
Thank you so much. Thank you so much for the kind introduction. So I'm going to talk about Fontan liver disease and contrast ultrasound, and these are my disclosures. And Fontan procedure was first described in 1971, and this is to repair the cardiac malformations. This is a genetic congenital cardiac malformation with a single functional ventricle. And this is very, very complicated and typically done after several staging operations. I'm not a surgeon nor cardiologist, so I'm not going to go details in this complicated surgery and the procedure. However, as you can see on the right hand, basically this surgery will mix this blood flow from single ventricle, and so that these kids can survive. And with this procedure, it is reported 15-year survival is 95% on those babies. And there are always some degree of histologic liver abnormality in nearly universal in patients with a Fontan procedure. And they have congested liver disease, and some people will progress to cirrhosis. And however, true prevalence of cirrhosis is uncertain. And as a hepatologist, we often get consulted on those patients who are actually evaluated for heart transplant and if they need liver transplant or not. Now, it is well known these Fontan liver disease develop those arterialized nodules. This paper is a review of 27 consecutive Fontan patients who had CT scan over a 4-year period. And among them, 26% of patients had a median of 4 arterial nodules. It ranged from 1 to 22, and mean size was 1.8 centimeter. And all nodules were located in the liver periphery, and 2 were biopsied and showed FNH, focal nodular hyperplasia. So these are typical Fontan nodules. Now, those FNH, or FNH-like nodules, are often seen on patients with Fontan-associated liver disease. However, these congenital heart disease and Fontan circulation can also lead to cirrhosis, and they can also develop hepatocellular carcinoma, or HCC. Now, imaging can be very difficult with CT and or MRI because of epicardial leads. They may not be compatible with MRI. They also have an intra-abdominal device, and that may cause streak artifact on the CT scan. And to date, there's no report on CUS on Fontan liver nodules. So we aim to investigate the roles of CUS to characterize liver nodules in patients with Fontaine-associated liver disease. To date, we have enrolled 24 patients with Fontaine-associated liver disease and liver nodules, and we examine with CEUS. 14 male and 10 female. Age average was 29-year-old, range from 15 to 53-year-old. We have IRB approved protocol. We also did CUS on some clinical exam. We use either Rumison or Definity as a contrast agent, and ultrasound machine use was Canon GE machine. And we did standard liver protocol with real-time low MI imaging to evaluate arterial phase and intermittent imaging in the portal and late phase to evaluate for washout. So let's look at some of the cases. This is a 23-year-old man with Fontaine-associated liver disease. And this is an MRI of this patient, and you can see multiple arterially enhancing nodules throughout the liver. Now, these are very interesting nodules as there are some shows different features. So this one is a segment 2 nodules. You can see 16 millimeter arterial phase hyperenhancing nodules. And in this one, there's no washout, and there's a mild restricted diffusion on MRI. Now, other lesions like these segment 7 and segment 6 lesions, as seen pointing out with arrows, these are also hyperenhancing nodules on arterial phase. However, as you can see in the lower lobes, these lesions actually wash out and shows capsules. And whenever we see those washout, as you saw in a beautiful presentation by Dr. Wilson, we need to worry about malignancy. And if this is a cirrhotic patient, we know these are Litus 5 lesions, very concerning for HCC. So this is an ultrasound. You can see most of them are hyperechoic lesions. I can see these segment 7, segment 5 lesions, multiple hyperechoic lesions. And then this is a segment 2 lesion on the left side, hyperechoic 20 millimeter. And the segment 6 lesion, this is 30 millimeter lesion. This looks different. This is isoechoic, and this was one of the lesions that showed washout and capsule. So let's look at the contrast ultrasound. So lesions right here on the left lobe, segment 2. And as you could probably see, I'm going to just remind, it starts in the center and rapidly progress to the periphery. So you see this centrifugal pattern from center to periphery, and you can see a little bit of spoke wheel or steroid vessels. So this is a FNH pattern enhancement. And this lesion, at 1 minute, 2 minutes, and 5 minutes, there's no washout. So when we see this enhancement pattern and no washout, we are very confident that this is FNH. So this is fine. Now, what about the other lesion? This is a segment 6 lesion that was isoechoic, and that showed washout and capsule on MRI. So as you could see, you actually saw right here, it's not dead center, but you can still see from the kind of center and steroid vessels, and then progresses to periphery. So this is a FNH pattern enhancement. And this lesion, so this is the arterial phase. And then you go to the late phase. And interestingly, 1 minute, it's enhancing, and even 5 minutes, it's still enhancing. So I actually do not have an explanation why these nodules showing washout and capsule and MRI, but no washout and persistent enhancment in the contrast ultrasound. I don't have an explanation. Maybe Dr. Kriebert or Dr. Wilson have some insight to it. But when we see this, we are very confident this is a benign lesion, non-malignant. And then we did not look at each lesion. There are multiple lesions, but you can do this late phase scan. This is 7-8 minute scan, And you can see other nodules are not washing out. They're all still hyper-enhancing at late phase. So I was confidently say these are the benign lesions. So you can see the benefit of doing CEUS on this type of case. Next case is a 19-year-old male with Fontaine-associated liver disease. And this patient has only one lesion, and in the segment 6, a fairly large 33 millimeter lesion with arterial phase hyperenhancement on the left side and washout in the right side. This is the CT scan. So whenever we see washout, of course, we are concerned about malignancy. And this is an ultrasound mild hyperechoic lesion, as you can see here on the gray scale. And this is a contrast ultrasound, and it's hyperenhancing. And as you could probably see, it comes from outside to inside, right? So this is a very different pattern from the nodule you just saw. So the hyperenhancement in arterial phase from outside to inside, and no washout at 1 and 2 minutes. However, it shows a very late and very mild washout at 6 minutes. Now, whenever we see this washout, we need to worry about malignancy. So we sent the patient to biopsy. And this was a hepatocellular adenoma. And there are different subtype of adenoma. And this was a hemp-1-alpha inactivated hepatocellular adenoma, which is different from beta-catenin abnormal, the activated adenoma, which is more associated with HCC. And the hepatocellular adenoma may wash out in any modality, including CUS. 40 to 50% of them can wash out. And in a risk patient, you cannot differentiate from HCC because the pattern is very, very similar. So we need to do a biopsy, patient at risk. But if patient is not a risk patient, then we usually can be pretty confident that might be an adenoma. Next patient is a 30-year-old male with Fontaine-associated liver disease. And this is a CT scan, very poor quality. And you can see the artifact. You can really evaluate the left lobe. And on the right lobe, you can see some enhancing areas, maybe some enhancing lesion is what we had on the CT scan. On ultrasound, you can see multiple lesions, hyperechoic lesions. This is left lobe and the right lobe. And there's actually venous shunt in the right lobe. You can see right here. And then there's a nodule next to it. So let's look at this. So this is on the right side, the big hyperechoic nodule, and there's a venous shunt next to it. It's kind of interesting case. So it's a little bit difficult, but pay attention right here on the nodule. So there's a enhancement going on here. It's probably very difficult to see. I will show you in a still images and MIP. And then as you go here, you can see this venous shunt. It's a portal vein to hepatic vein shunting. So that was the contrast ultrasound. And so this is the nodule that we're talking about. You can maybe imagine some scared vessels in there and no washout. And I'll show you the MIP imaging. It's a little bit easier to see on the MIP, still difficult, but it's a centrifugal pattern. So this is a FNH-like nodule. Now, let's look at the other one. This is a hyperechoic nodule on the left lobe. And let's see, I'm going to just fast forward. So here you start seeing nodule right here, hypoenhancing. But as you keep watching, it actually fills in more and more. Not really, I couldn't see a typical nodular, the discontinuous nodular pattern, but you can see it's actually progress enhancement to the center as time goes. So this is early phase, and then I'll show you 1 minute, and then by 2 minutes it fills in. So this is a hemangioma. And then this case is a 39-year-old female with Fontaine-associated liver disease. She has very different lesions, rim enhancing lesions on a CT scan. Again, you see this artifact on a CT scan, but you can see this multiple rim enhancing lesion. This one's a little different, but everything washes out. So these are very concerning lesions. And then on the ultrasound, these are mostly hypoechoic with some hyperechoic rim. This one doesn't have a rim on the right side. And this is the CUS. The lesions right here. I'm gonna just control this one. So right here, you see the rim enhancement right here. So this is a atrial phase hyper enhancement with rim at the beginning. So let's see. So this is a rim enhancing rim aphy, and then it's actually washes out early and marked. So this is very concerning to malignancy. And we biopsy 2 of those lesions, and this is a portovenous washout. Other lesions are washing out. And this is hepatic epithelioid hemangioendothelioma. It's called, we call it HIHI. This is considered low-grade malignant lesions, and unfortunately, these can metastasize. And for this patient, this is actually more higher-grade malignancy, and she ended up in metastasizing these lesions. So that was the case. So to just summarize what we've experienced, we've studied 24 patients, and on 4 patients, we did not see nodules on ultrasound. And then on 20 patients, we evaluated 26 nodules, and we evaluated 6 patients, 2 nodules on 6 patients. We had more nodules, but we didn't evaluate each single nodules. And then there have been 3 deaths. One patient died after heart and liver transplant, and 21 patients died. One of them had a heart and liver transplant, and 1 patient had heart transplant and survived afterwards. And so what happened on those patients who we didn't see nodules? 2 cases were very small nodules with only hepatobiliary phase uptake on neobis on MRI. So we thought likely those are regenerative nodules. And then there was 1 stable 9 millimeter small lesion on CT that was thought to be likely a fresh vein hemangioma or perfusion abnormality. We didn't see it on the CUS or on grayscale ultrasound. And then there was 1 case who underwent heart and liver transplant, and X-scan showed 25 FNHs ranging from 2 to 25 millimeter. This patient's ultrasound was just very, very difficult. However, on the scan after injection, I saw 1 hyperenhancing nodule, and then some images, but difficult. It was difficult to evaluate, and there was no washout on any on the liver when I scanned in the late. And then among 26 nodules we evaluated, on the pre-contrast, most of them, 17 cases were hyperechoic, and these were the results: 1 adenoma, 2 regenerative nodules, 3 hemangiomas, and 11 FNHs. And then 4 isoechoic nodules, 1 regenerative nodule, and 3 FNHs, and 5 hypoechoic nodules were 1 FNH, 2 HIHI, and 2 regenerative nodules. So various, echoic, the echogenicity, most of them are hyperechoic, but of course, we cannot characterize by just looking at the grayscale. So on the arterial phase, 21 cases showed hyperenhancement, 15 with centrifugal spoke wheel vessels, and 14 of them did not show washout. So this is FNH, and 1 nodule showed washout. So we did the biopsy, and actually this patient also went liver transplant, and this was a FNH on both biopsy and transplant pathology. There was 1 centripetal hyperenhancement lesion with washout. You saw this was an adenoma biopsied. And then there were 2 rim enhancements with early and marked washout. These are PHIHI, and there were 3 hemangiomas. There were 5 iso enhancements without washout. And in a portovenous phase and late phase, 22 nodules showed no washout, and among them, 14 FNH, 3 hemangiomas, 5 are likely regenerative nodules, and 4 nodules showed washout. And again, 1 adenoma, 1 FNH, and 2 HEVs. So to summarize, CUS is useful for characterization of Fontaine-associated liver nodules, and CT-MRI can be challenging due to epicardial leads and or intra-abdominal device. Most common nodules are FNH-like nodules, best characterized by CUS due to high temporal and spatial resolution, capable of showing spoke vessels and centrifugal pattern enhancement. Other benign lesions such as hepatic adenoma, hemangioma, can also be seen on patients with Fontaine-associated liver disease. Rare lesions such as EHE could be differentiated from other benign lesions by CEUS. And it is critical to be able to differentiate HCC from other benign nodules on patients with Fontaine-associated liver disease, as they can develop HCC when progressed to cirrhosis. However, we did not have HCC case, so this will be in a future study. And we are planning multi-center prospective study to further evaluate the role of CUS in Fontaine-associated liver disease. Thank you so much for your attention. And I think we will do a Q&A later. And Dr. Wilson, would you introduce Dr. Quibert?
Yes, that's fine. I'd love to do.
Great.
So our next, that was wonderful. Thank you so much. And our next presenter is Dr. Dirk Klevert from Munich. He is a personal longtime friend of mine because he holds a wonderful meeting with Hans-Peter Westcott in Germany every year, a contrast-enhanced ultrasound meeting. And I highly recommend that any of you who want to take a little trip to Germany while you're learning something, that you consider going to his meeting, because it's truly wonderful. So Dirk is a very accomplished ultrasonographer. He's a professor of radiology. I will not pronounce your hospital, but it's in Munich. And he does, I think he and I do the most contrast ultrasound of any people in the world. And so he's a great enthusiast. And today he's going to talk to you about something that I know is of great interest to so many people, and that is the use of contrast-enhanced ultrasound in pregnancy. Dr. Klevert.
Dear Stephanie, first of all, could you see my slide? Everything is fine, and my voice? Okay, I'm very thankful for this very friendly introduction, but honestly, you are the king of contrast, so you do more even than I. So these are my disclosure, which have not any effect on my talk. We know that ultrasound is used in pregnancy every day, so we think about everything is fine, we look about the growing, but unfortunately sometimes we also find that a lesion detected incidental, especially in the liver. Therefore, we have to think about what might be the best way to monitor this lesion or to characterize this lesion. Of course, we have some limitation if we think about CT or MRI due to the fact that CT have either unit contrast and also radiation dose. And of course, MRI, we can use it, but the most time we should not give contrast. Otherwise, the baby will have the whole time the circulation of gadolinium inside. Therefore, our thought will, why should not use contrast in this setting? So our first study, we think about our examination from 2005 to 2014. We only include 6 pregnant women. The mean age was 32 and the pregnancy mean was 21 weeks. Afterwards, these results, we include another 22 patients, but I will first of all show you the first result from the first 6 patients. All patients give informed consent, and my recommendation will be also that the husband will probably sign this informed consent. That's better. We know that an off-label use for Lumason in Germany, it's called Sonovy, but we also know that there is no option available. All examination will be done by myself, and we use, of course, different equipment as you see. Every examination starts with a basic, so we look for grayscale, we look for color Doppler, and afterwards we also check the baby whether the baby is live before, because it's important that you don't make any mistake before. So the amount of contrast depends a little bit on the system you're using. It's between 1.2 to 2.4. It depends on the system and also on the probe. If you use a high frequency probe, there you should use more contrast. If you use a standard abdominal probe, 1.2 to 1.6 will be fine. My first case is a 20-year-old female. She's pregnant, 24 weeks. She had got rectal bleeding. She underwent CT. An unclear lesion was detected in the CT examination. Native B-scan show a hypergenic lesion in the right liver lobe in segment 6 with a diameter around about 4.2 centimeters. So we start again with contrast. We use also in this case the fusion tool. So you see this lesion show a strong uptake. In the middle, it's less uptake, but you also see that this lesion, if you look very slowly there, it starts to wash out. So if you look for malignancy, every lesion which have a strong uptake in the beginning and a wash out later has got a high suspicion of METs. Unfortunately, we could confirm that it's the METs, and also in the MRI, you see this was rectal cancer detected later. This was really a horrible day because, of course, the woman asked you, what do you see? There's another case. So this is a 34-year-old woman. She was pregnant 12 weeks. She had got epigastric pain. That's the reason why she went to a house doctor. The house doctor found an unclear lesion in the left liver lobe, and he had no idea what kind of lesion it is. So he was sent to our department, and we see this hypergenic lesion. There it is. Due to the fact that the heart is very close, we get a couple of artifacts there. So color Doppler is not very helpful. Then we repeat the examination. And I was very lucky because we see this lesion doesn't show any uptake in the beginning. This is around about 25 seconds after injection. Then we go to the portovenous phase. It's after 1.5 minutes injection. Still no uptake. This means it's no vascularization. And even after 3 minutes, no uptake. So my suspicion was that's probably a hydrated cyst. And this was also confirmed later by serology. The patient also underwent MRI. They detected, and after delivery, the woman go under surgery and they removed this hydrated cyst in this case. What is important is that, as I told you, you should start to look at the baby before you start. You see baby's movement, that's fine. And you also see that the placenta is here and no contrast arrived inside. The white dots you see, these are shadowing from the bones. These are no contrast. You could also prove it because if you birth, they're still existing. So baby contrast will no entered to the baby. Another case, we also use the fusion tool. This is a 20-year-old female. She was pregnant, 35 weeks. She disclaimed that she had got abdominal pain. And of course, the doctor said that's due to the fact that you're 35th week of pregnancy. That's normal. She also had an MRI, and the MRI described FNH. If you look carefully at the MRI image, even in the fusion tool, it doesn't look like really an FNH. By looking at color Doppler, we see some vessels. Yeah, might be very similar like FNH, but we have to prove it. So when I look at this information, I was confused after 2 seconds because, as Yuko already showed you beautiful images of an H, this pattern will not fit with an FNH. You have no central uptake. So, and unfortunately also see that this lesion now starts to wash out. And even if you look later, wash out, this means this is cancer. And of course, we have now to think about what will be the organ of cancer. There's only 2 options. You have to get biopsy. So you see, I biopsy this liver lesion. And unfortunately, the primary tumor was pancreas cancer in this case. Also, very, very sad story. When I summarize our first 6 women, we have done the examination. We said we could not find any side effects. And in all this 6 women source was very helpful. I have summarized all this information in this table. Due Due to the fact that we published this in a journal, we get a lot of women coming afterwards to us to follow up different liver lesions, and we also expand the use of contrast in pregnancy. For example, this was also a 29-year-old female. She was pregnant 12 weeks. So she had got abdominal pain. She underwent MRI without contrast, and they wrote, could be necrotic tumor, could be abscess, could be dehydrated cyst. Unfortunately, all these diagnoses have different treatments. Therefore, she go back to us and we should do the examination again. So we see this hypergenic lesion here. If we look at Doppler, we could not see vessels there inside. So either the Doppler is not good or there is no vessel. That's the key question. So then we go to contrast. You see very strong rim enhancement here. In the periphery, in the center, there is no uptake. And if you see this pattern, you know exactly this is an abscess. So very lucky, no tumor. And of course, this woman gone under drainage to remove this abscess. Another woman, as I told you, we expand the rule. This was a 27-year-old female that was in the 21st pregnancy week, and she found a new mass on the abdominal wall. We see there's a mass. This mass has got a diameter probably around about 2 centimeters, so very easy to see. Unfortunately, there is less vascularization inside, and the baby is also very close. Due to the fact that I don't want to maybe biopsy necrotic changes, I thought to improve the diagnosis and to minimize risk for the baby, it will be great if we see whether the complete tumor show perfusion or there might be any necrotic areas where we should not place our biopsy. You see the biopsy, the tumor is very close to the baby. And of course, there is a risk. That's the reason why we look for the best view. But you see, baby is moving. So also here you see everything is fine. But still now we have to think about where to place the biopsy. By looking at contrast, you see a very, very nice uptake of the complete tumor enhanced, so there is no necrosis. This information was for me very, very helpful because now I know it doesn't matter where I place the biopsy, I will get good tissue afterwards. So I place a pathway where the risk for the baby is very low. As you see, was my pathway, so not too close to the head. And you see there's a biopsy done afterwards. There we place biopsy, and this was a desmoid fibromatosis of the abdominal wall in this case. This is an expand of our indication. So this was a 32-year-old woman. She was pregnant 24 weeks. She had left side abdominal pain, but unfortunately has also polycystic kidney disease. So as I told you, we start our examination. You see heart is moving fine in the baby. Then we go to the kidney and you see there is a lesion in the middle of the kidney, which is not as echo-free as we look, for example, at the other cystic lesion. So either it's a hemorrhage cyst or maybe it's a tumor. Therefore, also we could not solve this problem by just looking at color Doppler. We inject contrast and you see only the sept show enhancement, but this is just a hemorrhage cyst inside. So in this case, there is no need for treatment. Also, the behavior of the uptake is not like an abscess, it was just a hemorrhage cyst. And this information was helpful to make a clear diagnosis if there is any intervention needed or not. Another woman, she was 36 years old. She was in the 34th week of pregnancy. She did claim abdominal pain, and the suspicion was a necrotic myoma. So really a rare diagnosis. We start our examination, look at the baby, everything is fine. But we also see there's a huge myoma there. And the question is this now really a necrotic myoma, which are the reason why the patient had got pain? By looking at color, we see only some tiny vessels here, but we couldn't detect any vessels inside. Now repeats the examination with contrast, and you see the complete myoma show necrotic changes inside. There is no uptake, a little bit there, but nearly everything of the myoma has no uptake. Even here, the later phase, it's complete necrotic, so inside. So it confirmed the diagnosis that the patient maybe have a necrotic myoma, and we can say, yeah, it's complete with no uptake of contrast. Even later, you see, after 2 minutes, even if you combine it with Doppler information, no vessels inside, so it confirmed the diagnosis. And again, look at the baby, the heart's movement. You see, these are bone artifacts, but inside of the baby, no contrast is inside. So it never passed the placenta in this case. This is a very rare case. So the young woman with the age of 30, she was in the early pregnancy with 8 weeks, and she disclaimed also abdominal pain. So you see the baby is very, very small, but we still see some movement of the heart inside. So you see how good color Doppler could be. And when I look at this image, I was a little bit confused because there's a couple of pathologies which should not exist. We see part of the portal vein, which starts here. Then we see the splenic vein, which have some thrombotic changes inside. So we see there is some thrombotic changes in this area. Then we look at the portal vein. I see a very strong hepatic artery, but I could not detect any flow in the portal vein. And we repeat the examination. You see complete occlusion of the beginning of the portal vein, complete occlusion of the splenic vein, and also on the SMV is also occluded. And also we see that the portal vein here is occluded. Due to the fact that this woman had got pain and there was an increase in the lab, they have to meet a treatment. I just repeat the examination. And then we here, that's the splenic vein. Again, you see the occluded, and now we see the portal vein in this area. So they do intervention. The woman comes back to me next day. They didn't tell me what kind of intervention they have done. They just said, we do intervention, just check whether everything is fine. So I start again, look at the baby, everything is fine. And then I was confused because I didn't understand what they have done. I thought they would like to try tips, but they told me that it's not working. So they do a direct puncture from the IVC to the main part of the portal branch. So this is a covered stent from the IVC, which entered in the celiac trunk in the beginning of the portal vein. And you see also a nice perfusion afterwards here in the stent graft. So we see that looks not bad. Contrast arrived, so we have now a little bit more blood because the mesenteric vein had not enough blood in the past. Due to this stent graft, they could solve this problem. And you see that now the mesenteric vein also received more blood in comparison to the beginning. But the problem is that the mesenteric vein had some problem with the blood supply. Again, you see stent graft, still thrombotic changes in the splenic vein, also part of the portal vein. But due to this intervention, baby survived, everything is fine. I checked her 1 year later and both was in pretty good shape. Another 24-year-old woman, she was pregnant, 19 weeks. An unclear liver lesion was detected. We see there the lesion. We see a couple of vessels inside. So we have to check what kind of lesion we're talking about. Important is where contrast arrived. And remember these beautiful images Yoko have shown you just before. Also here you see the first bubble arrived from the center. I will start the video again. You see from the center to the peripheral, no washout in the portovenous phase. And if we look later, that's after 2 minutes and 2.5 minutes, late phase, no washout. So this is just an FNH. Also in this case, there is no need for treatment. I just have to go short out of my presentation because the computer is stocked, but now it should be solved. You see even in the late phase, no washout of this lesion. This is a very, very interesting case. because that's a 31-year-old woman. She was pregnant 22nd week. Unfortunately, she had got rectal bleeding, and in the MRI, they find rectal cancer. In the MRI, they also described that this patient suffered from liver cancer in both liver lobes. You see in the left liver lobe and on the right liver lobe. This will have got a major influence, of course, on treatment, how to solve this problem. So we just now, this woman come to us to confirm that both lesions are liver cancer. So you see the left liver lobe and the right liver lobe. So we see there's a lesion, but we also see there's a lesion. In the next step, we look before we start at the baby. Baby is fine. Then we look, this lesion show a perinodular enhancement. This lesion show complete different behavior. See a strong uptake in the peripheral, the completion is filled with contrast in the arterial phase. Then we have to go to the portovenous phase to still see perinodular enhancement, no washout. And this lesion have got a complete different behavior, clear washout. So after 1.5 minutes, you can tell exactly this is liver mets in the left liver lobe. This is a hemangioma on the right liver lobe, and this hemangioma have to not to be treated. Even later, after 3.5 minutes, you see clear, nothing changed, still wash out. And here, after 2.5 minutes or nearly 3 minutes, still filled with contrast. So it confirms the diagnosis of hemangioma and liver mets. This was very, very helpful because this means only that the patient have to be one mets on one liver lobe and not on both liver lobes. What are the steps I would recommend? First of all parents should give an informed consent. That's important from my point. You have to think about before you do the examination and give them enough time that they have enough time to think about they really like and not like it. Before starting the examination, in order to avoid any problem in the future, check whether the heart of the baby is working fine, yes or not. You can also do the examination, or you can use the contrast for planning intervention and do intervention. If you are finished with all your examination, go back to the baby and check whether the heart still, everything is fine. Also show the images to the ladies because they feel much better if they see their baby before and afterwards. So to our results in this study, we had no side effect, and we can say in our study group, it's a very safe contrast agent and have got a very important influence on diagnosis and also treatment. To my knowledge, these are the one or two largest cohort which focusing on pregnant women by using contrast and ultrasound. We also expand the rule that we use it now for kidney, we use it for intervention and also for vascular diseases. Think about that the contrast will not pass the placenta, so you can tell them it's safe. And as I told you, we expanded, we use it for kidney, uterus, and vascular diseases, and I'm sure we will find more and more good indications in this case. So in case you would like to join us in Munich, you're welcome. Stephanie and Yoko also will be there. And if you need some more training cases, use your mobile phone and scan the QR code. We have around about 600 training cases for you there. It's in English, so you could feel fine, and you must not be a member. Thanks a lot for your attention. I'm open for questions.
Thank you, Dirk. That was wonderful. I thoroughly enjoyed it, and I'm sure everyone in the audience did as well. And so right at this moment, I only have one question in the chat box. And so I'm quite sure there must be other people who have questions. So if you could maybe type a question in, and we will proceed to answer the first question. So the first question is from Victor Zeloff, who I know. Welcome. Professor Wilson, based on your experience, are there any differences between Definity and Lumison in detecting late phase washout? And so actually, I think Dr. Kono and Dr. Cleaver will help me to answer this. But essentially, if you look at an examination that was performed with Lumison or Sonoview being the same agent, or Definity. When I look at the examinations, I cannot tell whether they were done with one agent or with the other. However, when we're actually doing the scan, there are perhaps some slight differences. I think that Definity is a little bit of a tougher bubble. And by that, I think the importance of that is this. If you're looking at patients, the question of washout is a very big challenge. When you consider patients with liver disease, where they might not have good portal venous phase enhancement of their liver, fatty liver, different things can alter. And then in addition, the amount of time that you've scanned, that can alter as well. And so sometimes when the patient has a malignant lesion with very, very late washout, and Dr. Kono did show a very late one, and I believe I did as well, very late washout, I think Definity is often still around a bit longer than Lumason. So in other words, at 5 or 6 or 7 minutes, Definity can often still be there, especially in a patient with good liver. So we might notice a difference in washout detection. But other than that, I feel that both contrast agents are very similar. They're from the same generation of contrast agents, and they're just made by different manufacturers, and they have different bubble structure, but they are extremely similar. Dirk or Yuko, would you like to add anything to that?
No, I absolutely agree with your stuff. As I told you, Definity is a little bit more stable. So in the late phase, you could also sometimes increase the MRI to get more penetration depth with less destroying of bubbles for a short moment. So Definity will have some slight advantage there. But important is, don't use the same preset exactly. So you could not do Sonovue and Definity. So you have to optimize also according to the contrast agent you're using in your system.
Yes, that's a very important comment that Dr. Cleaver just made. And so if you have a machine that's been optimized for one or the other contrast agents, although you might get away with doing it without making changes, it's always good for the manufacturers to know that you're going to use both agents, and you have a setting, a pre-setting for the use of either agent.
And I agree with both of you. However, in my experience, I use both, and but in a clinical setting, I use mainly Lumason just because of the FDA approval, although we could use Definity. And I didn't do a head-to-head comparison, but it's more, how long you can see this late phase enhancement is, to me, it's more patient dependent. Like even with the Lumason, I had some patient, like I could see, the hepatic parenchyma enhancement, like 8-9 minutes, usually not that long, but so there are also patient factors, but both work.
Yeah, and they're both very good. Now, are there any questions that anyone would like to put their hand up? I'm not quite sure how that works. Otherwise, I will ask a question. So Victor Zeloff, welcome to our meeting. We're very happy to have you on our call. But so, Yuko, I thought that we should make a comment about those exceptional cases that you showed, where like the standard situation when we discuss washout is this. When we're looking at hepatocellular carcinoma in particular, is that many tumors are LR4 on MR scan. So they show APHE and they do not show washout. And we convert so many, it's uncountable. Many of those are LR5 on ultrasound. And so as long as your interventional radiologist and your multidisciplinary committee will accept the use of ultrasound, which certainly I know for Yuko and Dirk and myself, yes, that would be the case. So then you save doing biopsy on all of those patients prior to doing your therapy, unless you biopsy and ablate. But so Yuko, so what's quite interesting to me is that you're describing cases with the reverse happening, where the patients actually have washout on MR. And you did ask us, do we know the answer? I will confess, I have absolutely no idea. What do you think, Dirk?
There might be tiny shunts there.
There might be, but heavens, that, well, and so all I will say is that, as I really strongly made the point when I was giving my own talk, I think that ultrasound's great advantage is resolving things that you see on MR scan. So I think that that would be great if we added this to the things that we can solve with contrast ultrasound that appeared on MR. But no, that's most interesting. So Dirk or Yuko, do you have any questions?
I have a question to Dirk. Thank you so much. It was very, very interesting, and I feel more confident. I've done maybe a few cases on the pregnant women, but of course, we were kind of careful in this patient really, really need a contrast study. And with the experience and really, highly confident that it's safe. And then I think it seems like you've been selecting the cases that really, really high impact, really risky or concerning cases and very interesting cases. But with your experience now, would you feel more comfortable expanding to those maybe not really too concerning, but but we don't know the answer? We could potentially wait till the delivery, but we kind of want to know. Would you feel comfortable expanding, or we're not there yet?
It's often a question of the pregnant woman. So can she have a good life until she delivers the baby for my 5-6 months didn't know what exactly is in her liver? Or will she live better if we could make a diagnosis early? Unfortunately, sometimes we have lesion which looks in the gray scale as a benign lesion, sometimes hemangioma. And unfortunately, this lesion also could show up like behavior of liver mets in contrast. So if it will be my wife, I will tell her, please do it if you agree, even if it's not 100% sure.
No, so Yuko, as both of you are aware, Abdominal Radiology just published an entire issue, a special issue devoted to imaging pregnant women during pregnancy. And not only did they not include contrast enhanced ultrasound, they didn't even include ultrasound. And so I hope this was just an oversight and not intentional, but regardless. But so we actually have a manuscript that we've been preparing for a long time. And so now that I'm looking at it, Yuko, your question really, really hits home how I feel about this. And I know it's how Dirk feels as well. And so I think that the thing that's tremendously valuable about being able to do contrast ultrasound in pregnancy without worrying is the fact that it allows us to basically manage problems that we're presented with as we always handle them. And so, for example, I think it's important that Dirk just alluded to this, like some masses are benign, but knowing that they're benign, sometimes they can be big and look bad. And even if we kind of think it might be benign or might be malignant, we might be wrong. And so certainly if there's questions where there's even relief of anxiety, I think that many women are very happy to have the scan. And then in addition, like, let's just take the thing that's really closest to your heart, Yuko, yours and mine for sure, are these patients that come as part of the hepatoma screening program. And so we have a patient recently who I believe had HBV and HDV. And so she's very high risk. She's an older pregnant patient, over 40, and she has a new, almost 2 centimeter, very black nodule in her liver. And so it's very anxiety producing for me to say to her, I'm really worried about this, but I'm going to wait just because I'm anxious, and I'm not anxious anymore because of Dirk's wonderful exposure to us. And so we try to handle the patients as they present. And then the other thing is, Dirk, you showed a exceptional case of a patient with a fibroid complication. And so patients with inflammatory bowel disease who have acute episodes or flares in pregnancy, and patients with acute GU complications like torted fibroids or problems in that regard, I think that the use of CUS in pregnancy is really, really just a terrific benefit. And so I'm so happy that you agreed to present that, Dirk. And so soon I will add a nice paper, I hope, to add to yours with pregnant experience. And I encourage people, and quite a lot of people from the US, Yuko, have kind of called me, Stephanie, shall I do this? And I say, yes, please go ahead and do it, because it will be good. That you agree, Dirk? Yes, yeah.
Absolutely.
And I have one more question to Dirk. So you said we should do a consent form. is it IRB approved, or you just have just a direct consent for
Direct.
radiology?
Directly
Yeah.
consent form.
And-
Yeah.
Right. And then would you mind, maybe it's good to put an ICUS website kind of example of the consent form for that, so that people can use
It's the same consent form that we use for all ultrasound
Just
examinations.
a radiology.
Yeah, for contrast, because there are different
I
consent
see.
forms like CT or MRI, but we use this consent form is the same as we use it for standard contrast enhanced ultrasound examination. We only give them longer time to think about it.
So do you consent like CT, MRI contrast?
No, for every patient who gets MRI or CT, not a pregnant woman, they also have
Right.
to give an informed consent in Germany. Written conformance
So,
consent.
so this is, we've investigated this at ICUS also. And so this is very, very, very country related. And so in Canada, previously we did. I used to consent every patient that I gave a contrast injection to. But then prior to changing the CUS rules, the rules changed for CT and MR scan. And so now you have to make sure that you document that you have verbal consent. And so after several years where we continued to collect written consent for contrast enhanced ultrasound for everything, pregnant or not pregnant, but now they've decided that we were just amassing volumes of paper that nobody ever looks at, that aren't used, and that if we don't need it, we have to have verbal consent for doing our procedures always, but no longer require written consent. So I don't get written consent. But I agree with Dirk. I think there's an emotion here that's very important. And so I think it's always the best thing. It doesn't always happen, but the very best thing is if the man and the woman who are the parents of the baby are both there to agree. Yeah. But on the other hand, we have had a couple of patients now who have come alone, and they don't want to have their husband come. They want to make their own decision. It's there, and they're going to have the consent and on their own. So I think that that's a great question, but I think it would be independent or dependent on where you live.
Yeah.
Thank you.
And so, Yuko, I wanted to ask you one other thing. I don't understand why you didn't have any hepatocellular carcinoma.
Well, I think we had only 24 patients, and I think it's fortunate for the patient, and it's very rare still. And of course, when they develop cirrhosis, and then when they get older, they can develop HCC. So I think we will get HCC cases, but so far we haven't.
Oh, that's great.